Hi everyone, I hope everyone can hear me. I'm going to get started. My name is Larabe. I'm one of the pharmacy residents and I'm going to be presenting on multi-drug resistant microbial infections. So I have no financial interest or disclosures. And I just want to thank Katie for looking over my CE and co-authoring it with me. So some pharmacist objectives, we're going to describe the mechanisms of antimicrobial resistance. We're going to describe the etiology of emerging resistant organisms in the healthcare environment. And we're going to identify ways to control and prevent the development of microbial resistance in healthcare facilities. So we're going to start off with a patient case. So we have a 56-year-old female presenting with fevers, chills, and altered mental status. Her past medical history includes prednisone, interstitial lung disease, type 2 diabetes, and her home medications include prednisone, aspirin, insulin. And in terms of physical exam, she's complaining of pain in the lower abdomen, burning feeling while urinating, and a urinalysis and cultures are collected in the ED. So just to look at the UA, it is showing that it's positive nitrites and a small leukocyte esterase. And cultures are showing Enterococcus faecalis, and susceptibilities are showing VRE. So what antibiotics can we give and which antibiotic is this organism resistant to based on the susceptibilities? So I just want you guys to keep the patient case in mind as we go throughout the CE. So first, we're going to talk about how antimicrobials actually work before I get into how antibiotic resistance happens. So effects of antimicrobials. So there's different mechanisms by which antimicrobials act on organisms. And so there's different mechanisms of actions for all our antibiotics. So we have inhibition of cell wall synthesis. So that's your penicillin, cephalosporins, and vancomycin. You could also have alteration of membrane permeability. So that's like our polymyxins. There's also inhibition of protein or nucleic acid synthesis. So that's aminoglycoside, tetracyclines. And you can also have inhibition of essential folate metabolites. So that's like your trimethoprim. So when we're thinking about selecting the antibiotic for our patients, we can look at susceptibility. So that would show if the organism is susceptible to the antibiotic based on susceptible, intermediate, and resistant. So I have the definitions of these terms. So the selected drug, for susceptible, the selected drug is effective at the recommended standard dosage. If we're looking at intermediate, the drug is active, but effectiveness is less predictable. So that basically means like we're talking about the MIC or the minimum inhibitory concentration, which is the lowest concentration of an antibiotic that inhibits the growth of a given strain of bacteria. So we have to look at the relationship between the MIC and the achievable blood and tissue levels, and look at those levels to be able to decide that if we're going to be using an intermediate antibiotic to treat a patient's infection. And then there's also resistant, which is basically the selected drug is probably not effective by systemic administration and non-toxic dosages. So we would basically have to give a lot of that one antibiotic if a patient's resistant to it to even overcome the MIC to treat the infection. So now that we have a good background on just how antimicrobials work, I'm going to dive into what antibiotic resistance is and how it comes about. So per the CDC, the definition of antibiotic resistance is when germs like bacteria or fungi develop the ability to defeat the antibiotics designed to kill them. So it does not mean that your body is resistant to antibiotics. It's just the bacteria or fungi are resistant to the antibiotics. So the threat of antibiotic resistance in the US, so this is just some stats from the CDC. So it says each year antibiotic resistant bacteria, those are like our MDRO, like multi-drug resistant organisms. And they cause at least an estimated of 2 million infections and 3,500 deaths, which is a lot. So just some more epidemiology on multi-drug resistant organisms. So they're responsible for a growing epidemic, causing substantial morbidity and mortality, as well as increased hospital costs. The prevalence of MDRO has steadily increased during the last several decades in the US. Antimicrobial resistant rates strongly correlate to the type of hospital setting or long-term patient care kind of setting that we're talking about. Everyone is at risk for antimicrobial resistance. So antibiotic resistance can affect any person at any stage of life. And moreover, antibiotic resistance jeopardizes advancements in modern healthcare that we have come to rely on, such as joint replacements, organ transplants, and cancer therapies. These procedures have a significant risk of infection, and patients won't be able to receive them if effective antibiotics are not available. And that's like the fear with antibiotic resistance. Antibiotic resistance is not only a US problem, but it is a global crisis. So I do have a slide on just the global spread of antibiotic resistance. So resistant bacteria and fungi can spread across countries and continents because people constantly travel between countries, and it could spread through people, animals, and goods. So resistant threats are amplified in healthcare and communities. So the most deadly healthcare associated germs spread from patient to patient and across healthcare facilities. So like through patient transfer. So if you have a patient that's coming into the hospital from long-term care, like they're gonna have the certain organisms that are just kind of attached to them because they're going from a healthcare facility to a healthcare facility. And then when this patient transfer of the organisms isn't stopped, and the resistant healthcare associated germs can spill over into the communities, becoming much harder to control. So when infections in the community occur in the community, like they are more likely to be very resistant. So stopping the spread of resistant threats in the community requires tailored interventions such as good hygiene, routine vaccinations, safer sex practices, safe food preparation. And many of these interventions have already been proven successful, and I will be talking more about these strategies later on. So how does antibiotic resistance happen? So the main straightforward answer is that antibiotic exposure, it's like antibiotic exposure and the spread of germs. So increases in antibiotic resistance are driven by a combination of bacteria exposed to antibiotic and the spread of these MDRO and their mechanisms of resistance. So antibiotic resistance is a naturally occurring process, but it's accelerated when antibiotics are constantly present in the environment or patients are constantly exposed to them. So patients should always be promptly treated with antibiotics when the drugs are needed, but we just want to make sure like that they actually need the antibiotic and use them only when necessary and only for appropriate durations. So how antibiotic resistance spreads. So this picture I got from the CDC, it's basically showing like different steps of how antibiotic resistance can spread from people, crops, and animals that are sick to antibiotics that help kill germs, but then some of the antibiotic resistant germs find ways to survive. And then antibiotic resistant germs can multiply and then they spread. And then antibiotics also kill helpful germs that protect us. So if those helpful germs are gone, then the resistant bacteria has even a bigger advantage. And then once antibiotic resistant emerges, it could spread into new settings and between countries. So now we have a good background on antimicrobials and antibiotic resistance, I'm just going to talk about different mechanisms of antimicrobial resistance on like a pathophysiology level. So mechanisms of antimicrobial resistance. So there's overexpression of efflux pumps, loss of porins, inactivations of drug by enzymes, and mutations of different drug targets. So these are like the 4 different ways that we kind of learn in school. So I'm just gonna kind of dive into each of them and like what they mean and how the antibiotic is able to use a certain mechanism to have antibiotic resistance. So first one we have is our efflux pump. So that stopped the antibiotic from reaching its target. So basically efflux pumps are just pumps that pump the antibiotic out from the bacterial cell. And the overexpression of these efflux pumps really help the bacteria survive because they're being pumped out, or the antibiotics being pumped out from the bacterial cell. So some of these efflux pumps can transport antibiotics outside from the bacterium, and in this way lowering the antibiotic concentration inside the bacterial cell. These efflux pumps are very common in bacteria and can transport a variety of compounds such as signal molecules and nutrients. In some cases, mutations in the bacterial DNA can make the bacteria produce more of a certain pump, which in turn increases resistance because the pump will just pump out the antibiotic from the bacteria. There's also porin channels. So porins are outer membrane proteins associated with the modulation of cellular permeability. So less porins means decreased permeability of the membrane that surrounds the bacterial cell. So in this way, less of the antibiotic gets into the bacteria. There's also inactivation of drug by enzymes. So there are bacterial enzymes that can inactivate antibiotics. One example is beta lactamase, which basically destroys the active component of the beta lactam ring of penicillins. Another example is ESBL. So currently bacteria that produce ESBL have become a major problem. They can degrade a wide spectrum of beta lactam antibiotics, sometimes also the last resort drugs available for infections with these bacteria. And the last way I'm going to talk about is modify the antibiotics. So bacteria can sometimes produce enzymes that are capable of adding different chemical groups to the antibiotics. So this would actually in turn prohibit binding between the antibiotic and its target in the bacterial cell. There's actually multiple ways that bacteria can modify the antibiotic so it saves itself. So they can camouflage the target, so changes in the composition or structure of the target in the bacteria can stop the antibiotic from interacting with the target. So that's another way of resistance. So alternatively, the bacteria can add different chemical groups to the target structure, in this way shielding it from the antibiotic. Another way is expressing alternative proteins. So some bacteria are able to produce alternative proteins that can be used instead of the ones that are inhibited by the antibiotic. So these proteins are needed for the bacterial cell wall synthesis and are targets of beta-lactam antibiotics. And so the example would be Staphylococcus aureus can acquire the resistant gene MEK-A and produce a new penicillin binding protein. So the new penicillin binding protein has a low affinity to the beta-lactam antibiotics and is thus resistant to the drugs, and the bacteria can survive treatment this way. And then the last one, or another way, is to modify the antibiotic would be reprogramming the target. So sometimes bacteria can produce different variant of a structure it needs. So for example, vancomycin-resistant bacteria make a different cell wall compared to susceptible bacteria. The antibiotic is not able to interact as well with this type of cell wall. So that's another way or an example of reprogramming the target so that the bacteria is able to survive. And then now that we have a good background on antimicrobial resistance, we're going to talk about or discuss overview of multi-drug resistant gram-negative bacteria and multi-drug resistant gram-positive bacterial infections. But before we get into that, we do have a question for the audience. So what type of drug-resistant gram-positive / gram-negative infections do you see most frequently in your practice? You can type in the chat if you want. So basically what I was looking for here would be like your CRE, VRE, MRSA, and CRAB. All of those are examples of drug-resistant gram-positive or gram-negative infections. So I'm just going to talk about or give an overview on MDR gram-negative bacteria and MDR gram-positive bacteria. So just some risk factors. So risk factors for developing MDR infections can be multifactorial. So like we're talking about older age, long duration of hospitalization, if you have a presence of indwelling devices, if you have been in a nursing home for too long, or you have frequent encounters with healthcare environments, such as going to the hemodialysis unit. So all of these and having other comorbidities are risk factors of potentially developing an MDRO infection. So overview on MDR gram-negative bacteria. So in 2019, the Centers for Disease Control and Prevention, so CDC, published a report called Antibiotic Resistant Threats in the United States, listing and categorizing various types of drug-resistant pathogens. So among the 18 antibiotic-resistant threats listed, gram-negative bacteria such as carbapenem-resistant Acetobacter or CRAB, and then also carbapenem-resistant Enterobacteriaceae, which is CRE, were categorized as urgent threats. So that means you would require urgent and aggressive action. And then ESBL and multi-drug resistant Pseudomonas were categorized as a serious threat. So they require prompt and sustained action. So I'm just going to be going over each of the multi-drug resistant gram-negative bacteria. So we're starting off with CRAB, which is also known as carbapenem-resistant Acetobacter. So they usually cause pneumonia, wound, and bloodstream and urinary tract infections, and they tend to occur in patients that are in the ICU for a while. So CRAB basically is resistant to carbapenems in addition to baseline resistance to many antibiotic classes, leaving limited or no antibiotic options. So options to treat CRAB would be minocycline, tetracycline, ampicillin, sulbactam. They're kind of the mainstay therapy for CRAB. And on the bottom, I just have a graph that's showing basically the prevalence of CRAB in hospitalized patients from 2012 to 2017. So since it's got a little lower, continued infection control and appropriate antibiotic use are important to maintain decreases in carbapenem-resistant Acetobacter infections. And then now we're going to talk about CRE, so carbapenem-resistant Enterobacteriaceae. So what that means is that it's resistant to at least one of the carbapenem antibiotics like ertapenem, meropenem, or it produces a carbapenemase. So carbapenemase is basically makes carbapenem antibiotics ineffective and rapidly spreads resistance that destroys these important drugs. So patients who have like devices such as catheters or are at risk of getting a CRE infection. So options to treat CRE would be like your meropenem, ceftazidime, avibactam, cefidricol. So since carbapenem-resistant Enterobacteriaceae, so why would you use a carbapenem to treat CRE? You would only use like extended infusion meropenem to treat CRE if it's meropenem susceptible, but it would have to be the extended infusion. And then on the bottom, I have another prevalence graph, so just estimated cases of CRE in hospitalized patients from 2012 to 2017. So basically, continued strategies have prevented further spread of some types of CRE in the United States, but continued action is needed because, as you can see on the graph, it's like very stagnant from 2012 to 2017. So we have to continue using containment strategies to make sure CRE doesn't spread too much. There's also ESBLE, which is basically extended spectrum beta-lactamases producing Enterobacteriaceae. So ESBLs are enzymes that break down commonly used antibiotics such as penicillins and cephalosporins. ESBL producing often cause infections in otherwise healthy people. So options to treat someone with ESBLE would be like your carbapenems, our go-to, ciprofloxacin, levofloxacin. And I do have another prevalence graph on the bottom. So that's just showing ESBL in hospitalized patients from 2012 to 2017. And CDC and some partners are working to assess and address why cases of ESBL producing Enterobacteriaceae have increased since 2012. So that it's not really known why it's increasing, but it has increased from previous years. And the CDC is investigating it. And then the last multi-drug resistant gram-negative bacteria I'll talk about is multi-drug resistant Pseudomonas. So that's basically, Pseudomonas is like a well-known cause of healthcare associated infections. In the US, Pseudomonas is estimated to cause 3,200 infections and 2,700 deaths. And some antibiotics that we could use for multi-drug resistant Pseudomonas would be like your carbapenems, ceftazidime, and like the newer antibiotics like ceftazidime, avibactam, or ceftolozane, tazobactam. So now that we have a good overview on multi-drug resistant gram-negative bacteria, I'm also going to go over multi-drug resistant gram-positive bacteria. So among the 18 antibiotic resistant threats listed, many included gram-positive bacteria such as MRSA and vancomycin-resistant enterococcus, also known as VRE, to be a serious threat. So given the high prevalence and associated morbidity and mortality, we will focus on MRSA and VRE infections in the CE, even though there's like a lot of other serious threat gram-positive bacteria out there. So just like a little overview on MRSA. So it's basically when it's resistant to methicillin and considered resistant to other beta-lactam antibiotics except ceftaroline, because ceftaroline does cover MRSA. And options to treat MDR MRSA would be like your tadalafil, telvancin, omadacycline, minocycline. So telvancin is basically another glycopeptide very similar to vancomycin. Its coverage includes covering for like HAP and MAP associated MRSA caused by Staph aureus. Omadacycline is another drug that we do have in the pharmacy, and it inhibits protein synthesis by binding with the 30S ribosomal subunit. It has bacterial activity against gram-positive and gram-negative bacteria, as well as like Legionella and Mycoplasma. And then we also have VRE. So VRE is vancomycin-resistant enterococcus. So it's resistant to vancomycin and commonly resistant to other antibiotics like ampicillin. So options to treat VRE would be like linezolid, daptomycin, and quinapristine, dalfapristin, which is basically an injectable antibiotic, which has a very wide spectrum of activity against gram-positive bacteria, including MRSA and Enterococcus faecium as well. So now I'm going to talk about prevalence of drug-resistant gram-positive bacterial infections. Now that we talked about like overview and what multi-drug resistant gram-positive, gram-negative organisms exist. So first we have MRSA. So MRSA is a cause for global concern. It has been highly prevalent in many countries. It is a leading cause of mortality due to antibiotic resistance. If you look on the right side, it's just showing antibiotic resistance of Staph aureus in select countries. So the US has like the leading, has the higher rate of mortality due to antibiotic resistant infections in the US. And MRSA now accounts for approximately 45% of all Staph aureus invasive isolates, causing over 300,000 deaths per year and over 10 infections and over 10,000 deaths. And this map is just showing global spread of MRSA, so resistance of Staph aureus, amoxicillin over a global spread. So the USA is around 50 to 75% range because it's like on like the darker blue side. So, but as you can see, South America and Africa have almost 0% resistance of Staph aureus to amoxicillin. And then I'm talking about Enterococcus. So Enterococcus is a well-known cause of healthcare associated infections, which could include surgical site infections, UTI, and bloodstream infections. So in the US, Enterococcus causes over 54,000 infections and very like 5,000 deaths per year, with approximately 30% of those caused by VRE. So if you look on the right side, it's just showing antibiotic resistance of E. faecium in the United States. So antibiotic resistance of E. faecium in the US has been steadily around 75%. So it's been very stagnant from 1999 to 2016. However, VRE cases have significantly decreased in the hospital and in the community in 2017 when compared to 2012. So this graph is just showing VRE cases and how there's been a decrease in both the community and hospital cases over the years. And then prevalence of drug-resistant gram-negative bacterial infections. So that we talked about gram-positive, the prevalence of like MRSA and all of that. We're going to talk about gram-negative bacterial infections. So this graph, it's showing antibiotic resistance of E. coli in the United States. So this graph shows resistance of E. coli. So as we all know, fluoroquinolones have become resistant in the recent years, and this graph shows just that. It's showing about 33% resistant. The cephalosporins are around 15% resistant. And the reason why we kind of like to hold on to our carbapenems and like use them last line so much is because they have a 0% resistance to E. coli as of 2016. So you really want to always use like the other antibiotics first before like using the big guns like carbapenems. And then this graph is very similar to the last one, but now we're looking at the Klebsiella pneumoniae. So cephalosporins and fluoroquinolones have increasing resistance to Klebsiella pneumoniae when compared to carbapenems, but over the recent years, carbapenems have also begun to show resistance if we're comparing to the early 2000s to now. So if you look at the graph, like the fluoroquinolones are the pink line, cephalosporins are the blue, and it's showing increasing resistance, but the carbapenems are also showing increasing resistance as you go throughout the years. And then this graph is just showing global Klebsiella pneumoniae carbapenem resistance. So luckily for Klebsiella pneumoniae resistance to carbapenems, the US is more closer to 0%. But in order to keep the statistics true, we want to make sure we always de-escalate from the carbapenems and not to overuse them when not needed. And now that we talked about multi-drug resistant organisms that are serious and urgent threats and have an overall good background on antibiotic resistant mechanisms, prevalence, and we're going to talk about prevention strategies for antibiotic resistance. So prevention strategies for antibiotic resistance per the CDC. So on the left side, I have strategies that work in healthcare. On the right side, I have strategies that work in the community. So just to point out some few, so tracking and improving appropriate antibiotic use in the healthcare is really important strategy to prevent antibiotic resistance. Stopping the spread of resistant germs within and between healthcare facilities is really important too. But it's also very hard to do because that's just something you think about, like going from a hospital to another healthcare facility. It's hard to stop the spread of those resistant germs. And then in terms of the community, you want to make sure like there's safer food handling, improving antibiotic use everywhere. So counseling our patients on finishing their antibiotic course, and just counseling them on antibiotics in general. And then also making sure that your patients are vaccinated appropriately. But even though these strategies exist and they actually do help prevent antibiotic resistance continues to be a threat. So what are some challenges pertaining to antibiotic resistance? So some challenges that exist in healthcare would be like trying to stop the spread of germs from the healthcare environment and like just on the surfaces. So that's what I was mentioning before. And then introduction of emerging threats from outside of the US because people travel all the time in and out of the US. And then challenges in the community, so like poor hygiene, spread of resistant threats in the food supply, because if like someone's touching food and then it gets like spread, and then there's like if patients don't like get vaccinated, that's another way or like a challenge in the community for antibiotic resistance. And then people not fully finishing their antibiotic courses, that's another challenge in the community. So for further progress, the nation must continue to innovate and scale up effective strategies to prevent infections, stop spread, and save lives. So what are the pharmacist's role in managing multi-drug resistant gram-negative bacteria and multi-drug resistant gram-positive bacterial infections? So this is a very summary slide on the pharmacist's role. Then I'm going to talk about antimicrobial stewardship right after. So pharmacist's role is really valued on a team when we're talking about antibiotics and which antibiotics to start. As pharmacists, we know like what drug to appropriately select, the dosing, and any other drug-related information crucial to making decisions. We also have knowledge of like the new and emerging antibiotics, and we can be valuable when making decisions about adding new antibiotics to the hospital formulary and their role for hospitalized patients. And we also have a major role in management of antimicrobial stewardship program. Antimicrobial stewardship in hospitals around the country has become increasingly important as antimicrobial resistance grows and the new antibiotic agents come to market. So antimicrobial stewardship, pharmacists play a key part in antimicrobial stewardship, but first a little background on what exactly antimicrobial stewardship is, because the term is thrown around a lot, but what exactly is it? So ASPs can help clinicians improve clinical outcomes and minimize harm by improving antibiotic prescribing. Antimicrobial stewardship also optimizes the way the antibiotics are used and it to effectively treat infections, protect patients from harm caused by unnecessary antibiotic use, and overall combat antibiotic resistance. So hospital antibiotic stewardship programs can increase infection cure rates while reducing treatment failures, adverse effects, antibiotic resistance, and hospital costs and length of stay. So this is a picture I got from the CDC. So these are the core elements that the CDC looks for when like they're establishing antimicrobial stewardship programs in hospitals. And a big core element is pharmacy expertise or drug expertise. So appointing a pharmacist, ideally as the co-leader of the stewardship program to help lead implementation efforts to improve antibiotic use. Others to point out would be like tracking the use of antibiotics within the hospital, educating the team, like prescribers, pharmacists, about optimal prescribing and antibiotic resistance in general. So antimicrobial stewardship. So it's important to identify a pharmacist who is empowered to lead implementation efforts to improve antibiotic use. So that would be our pharmacists that are like trained in infectious diseases, but it doesn't have to be someone that's trained in ID. It would just have to be someone that's willing to take on like the leadership role kind of in terms of pharmacy when it comes to antimicrobial stewardship. And then these are some pharmacy-based interventions in terms of antimicrobial stewardship that pharmacists can play a very, very big role in. And it's kind of our interventions that we make when we think about antimicrobial stewardship. So documentation of indications for antibiotics. So making sure that you require an indication for antibiotic prescriptions. So this can help, this could facilitate other interventions like prospective audit and feedback and optimizing post-discharge durations of therapy and can improve antibiotic use in itself. There's also automatic changes from IV to oral antibiotic therapy. So that's just something that we all kind of regularly do, like switch from IV to PO, and that would actually make it easier for the patient to take their antibiotics as well. Dose optimization and dose adjustment. So using extended infusion administration of beta lactams for patients that are critically ill or have been infected with drug-resistant pathogens. And another pharmacy-based intervention is duplicated therapy alerts, so alert in situations where therapy might be unnecessarily duplicated. So that means like discontinue the metronidazole if they have Zosyn on as well, because there's overlapping coverage of the anaerobes. And other pharmacy-based interventions is time-sensitive automatic stop orders. So making sure that the antibiotic falls off or has a stop date on it. An example would be like using antibiotic for surgical prophylaxis because it has like 3 doses and then it stops. Another is detection and prevention of antibiotic-related drug-drug interactions. So an example of that would be like using fluoroquinolones and then using certain vitamins. You want to make sure that they're spaced out because that is a drug interaction with fluoroquinolones. And then the final pharmacy-based intervention that I have is restrict certain antibiotics. So I got this from Katie. So it's basically showing our restricted antibiotics, ones that are on formulary versus not on formulary. So restricting antibiotic is really helpful because then you really make sure that like those antibiotics are not really used, and you want to use all your other options that are out there first, and then really save these antibiotics for patients that really need them and are resistant to all the other antibiotics out there. So in conclusion, the US government agencies are tackling the complex threat of antibiotic resistance by using data to detect and track resistance, infection and prevention and containment, improving antibiotic use, sanitation, vaccines, diagnostics, and therapeutics. However, antibiotic resistance continues to emerge and spread. The world needs heightened vigilance and public health engagement to contain resistant threats. Public health action against antibiotic resistance is fundamental to save lives. So it's really important that we really practice the prevention strategies like that I talked about from the CDC, but also continue to really monitor the antibiotic resistance out there and really think about how to solve those challenges that I also talked about that still exist with antibiotic resistance. And now I'm just going to go back to my patient case. So this is the same patient case that I had in the beginning. The patient does have an active UTI infection because they're complaining of physical pain or like physical symptoms of UTI, and they also have a urinalysis that's positive. And the culture is showing E. faecalis, susceptibilities show VRE. So what antibiotics can we give to this patient? You can write in the chat. But basically what I was going for was was daptomycin or linezolid, just because I mentioned that before, and those can be used for VRE. And then which antibiotic is this organism resistant to base cell susceptibilities? So VRE stands for vancomycin resistant enterococcus. So you wouldn't want to use vancomycin in this patient to treat their UTI. And then I just have the answers here for your knowledge. And then these are my references. And then if you guys have any questions, you can type it in the chat, but I will send you the post-assessment questions after through email. Thank you for coming.